Insight 2021 is a festival of learning and sharing for the NHS, for local government and all our other partners. It's a joint initiative between the Strategy Unit and the Midlands Decision Support Network, and links to both of the websites for those are in the chat for those who want to find out a bit more. I'm Peter Spilsbury, I'm Director of the Strategy Unit, and I'm really delighted to welcome an extraordinary panel for our session today. They're here to discuss some of the ethical considerations and the practical consequences of those when seeking to address health inequalities. Just before I introduce the panel, the usual protocols for the session today, please. So please mute yourselves, cameras off probably generally, tweet away about the session, please. Any technical issues, raise them in the chat and the team will try and pick those up. If you get a moment, please introduce yourselves in the chat, because it's very helpful for us in planning these events to know who we're managing to reach. So please do that. And please put any questions you have for the panel in the chat. We hope to be able to take a couple of those at the end, but we will understand that there's hundreds of people on the call and the session's an hour, so we're going to be pressed to do more than a couple. So anyway, if I can welcome for today Kelly Beaver, who's the Managing Director for Public Affairs at Ipsos MORI and visiting Senior Research Fellow at King's College London. Dr. Julian Huppert, ex-MP, Director of Jesus College Intellectual Forum at Cambridge, physicist, ethicist, policy researcher, and Deputy Chair of NHS Cambridgeshire and Peterborough CCG. Then Professor Swaran Singh, Professor of Social and Community Psychiatry at Warwick Medical School, Director of the Centre for Mental Health and Wellbeing Research at the University of Warwick. And Swaran was a Commissioner for the Equality and Human Rights Commission for 6 years. And then finally, Professor Sir Michael Marmot, Director of the UCL Institute of Health Inequality and lead author of several seminal reports that have changed the course of NHS thinking and indeed NHS funding over the last decades. This is a massive topic, and we could spend weeks drawing upon the insights of this panel, but we've only got an hour. So we're going to bound the discussion a bit on what I'll call the ICS challenge, the Integrated Care System challenge. The new integrated care systems exist to decide whether to do more of some things and less of others, because they direct resources. And they need to do that in order to improve population health and well-being, and to do so equitably. All these decisions involve value judgments. There is surely no technocratic route that can answer, rather than inform, the question, do we spend more or less on this population or that one? And that means, I think, that ICSs need to get explicit about values and to think about what that means for securing legitimacy in their decision-making processes. So for today, I want us to think about that in the context of an ICS that spends NHS allocations, that's looking to address health inequalities and levelling up. And I want us to try to think specifically about what, in a sense, is an eternal question in healthcare, of how we weight the interests of the person or the patient sitting in front of us or on a waiting list for any kind of care, from prevention through to hospital treatment. How do we think about that person versus the persons who aren't known to us, but who have possibly greater needs? And how we think about that when all the evidence tells us that there are socioeconomic, ethnicity and other gradients that mean that those not sitting in front of us are on average those who are already more disadvantaged. So for the purpose of this conversation today, let's focus on NHS actions and let's make an assumption that resources are fixed, so that we are in a zero-sum game for the purpose of today's discussion. So first I'm going to turn to Kelly, who's going to share some slides to give us a quick run through what research tells us about the public's view on these questions. So over to you, Kelly, thanks.
Thank you, Peter, and thanks very much for having me along today. So I'm Kelly, Ipsos MORI, and I'll just give you a bit of an insight into where the public are at. Do the public actually care, and are they concerned about health inequalities? Well, we've been tracking public levels of concern about all things for over 50 years at Ipsos MORI. And we have, this is the chart from the Issues Index, which tells you what people see as the most or other important issues facing Britain today. And you can see that health inequalities and tackling it doesn't make the top 5. Over the last year and a half, of course, COVID-19 has dominated headlines and also public levels of concern. And we've seen things like Brexit rise and fall depending on the amount of political attention it's getting at the time. But inequalities more broadly doesn't seem to be making the cut as in terms of what is the top concern amongst the British public. But does this mean that it's not a concern? Well, no, that's not right. It is a concern. And if you look pre-2010, it was around 5 to 10% fluctuating of the British population who believed that poverty and inequality were some things that really needed to be tackled, that they should be a priority. So it was relatively low level. But in and around the financial crisis and the general election of 2010, we saw that rise. And we saw it continuously rise right through to the point of the general election in 2019, where it dropped. And it dropped, why? Well, lots of other things were dominating people's concerns, partly Brexit, partly COVID-19. But as we seek to come out of the pandemic now, we are seeing public concern move to some of those secondary issues and increasingly concern around poverty and inequality. But how does it compare to other types of inequalities? Well, if you have a look at this question, which we ask not just in the UK, but across a range of countries, you can see that the top 2 issues in the UK on the area and topic of inequality is the division in people's income and wealth, and also about where they live. And regional inequalities in the UK is much more of a concern and an issue than for our European neighbours. But it is there, and we do see number 5, health and life expectancy. And it's not to say either that health and life expectancy is not intrinsically linked to issues like income and wealth, where you live in the country, what race you are, and what your childhood experiences were like. All of these types of inequality are clearly interlinked. But when you look at it in isolation, 3 in 10 would say health and life expectancies is the top concern. But obviously COVID itself and the impact it's had right across the country has really brought people's health condition to the fore and health inequalities that were underlying in society to the fore more than it had been before. And so it's interesting now as we look hopefully to the future and being able to come out the other end of a pandemic, when we ask the public what really needs to be a top priority for the NHS, again, it's not necessarily health inequalities that comes to the top of that table. They're very much focused on waiting times, the delays that have happened, and focusing now on waiting times for routine services like diagnostic tests and operations. And beneath that, they're worried about the amount of staff in the NHS. They're worried still about vaccinations, and also given the amount of, I guess, coverage that we've seen of the impact on NHS staff of dealing with this pandemic, amongst many other things. The public want to see supporting the well-being of NHS staff as a priority. Down here at 17% is reducing inequalities in health and society. So if you looked at the top line statistics on where the public are at, you could be forgiven for thinking that it isn't a major priority for them. It's just one of many priorities. But that's why looking in more depth at how the public really understand some of the challenges that we face as a country in the area of health and health inequalities and how that differs by area, by your background and characteristics is so important. And trying to unpick some of the complexity. One of the best mechanisms we have for doing this is using qualitative methods like deliberative research. And I'll just share with you some of the findings from a study that we've done recently with the NHS in London, looking at how the public understand prioritising waiting lists. Because beneath the surface of that statistic I just showed you, there is an awful lot of complexity. And actually, when you ask the public in a more deliberative setting and you get into conversations with them around how the NHS should tackle some of these challenges, they do recognise that there is a need to prioritise patients. They understand that patients should be prioritised, but not just on clinical need. They think also around individual circumstances. Secondly, they see the process of prioritising as challenging and complex. They don't see it as a straightforward process, not just in terms of how you prioritise them, but what the impact that type of prioritisation has on the staff who have to make those decisions. And they recognise some of that complexity when you speak to them in more depth. The public want a range of information when they're asked to think about this as an issue in order to help them weigh it up. So they don't just want information on the clinical severity of individuals. They do want that, the severity of their conditions. They want to know their age. They want to know how long they've been waiting for, but they want to know more about the individual in the round. And as I said, clinical severity is the overriding concern. So is the condition that the individual is facing life-threatening? Is there a risk to life if we delay treatment? For example, the risk of a heart attack. Are there potential here for the individual to be the condition to deteriorate rapidly if they don't get treated more quickly? For example, the risk of blindness if you don't treat cataracts, but also wider risks. What about the other consequences that could happen to somebody? Are they more vulnerable by not having the treatment? For example, someone who needs a hip replacement, but ultimately could be having a fall in the meantime. So clinical severity is a concern, but there are lots of other factors that come into play when the public get an opportunity to debate and to talk about the complexity of how you prioritise. And what we see are three interlinking factors that dominated the conversations. The level of pain, really important, and people respected and understood the fact that people have different types of pain threshold, and the interlinkages between the level of pain and the quality of life that people can live. And that quality of life is something that came through in a lot of the conversations, but also age and prioritising the elderly and the old, because ultimately they will be dealing possibly with more underlying and wider health issues as well. Beyond that, the individual circumstances. So the public would want to know the circumstances of people in that priority wait list, in that list. Have they got people depending on them? Have they got children? Have they got other dependents for financial circumstances? And how will their health condition impact on them? But beneath the surface of the four issues I've just touched on, there were other secondary concerns that they were weighing up. The mental health and what the impact will be on the mental health of the individual and those around them. And very secondary then, the employment and financial status. What kind of impact will not treating this condition earlier have as an impact on the financial resilience and stability of the individuals concerned? So there are lots of things in the public's mind when you really get under the surface, and many of these are driven through inequalities. But the public do not like the idea of a postcode lottery. And I think they recognise the complexity of some of the challenges facing the country as we come out of COVID, many of which were there but are now exacerbated as a result of the pandemic. But when you look at wait lists as an issue there were so many other issues that the public think need to be considered. And a note of caution for ICSs as they seek to make decisions about where to spend resources and how to spend resources and how to get legitimacy for their spend decisions is that ultimately the public have a view that they would like decisions in the main. When you ask questions about things like treatments that are available on the NHS, would you rather that everybody is able to get it? It's only available if everybody can get it, versus actually, no, we need a really localized approach. There is this real clarity that the public don't want a postcode lottery in their specific area, but they do recognise that there is need for public tailoring as well. And when you look at how they perceive the NHS decision-making, fairness has always been, through all of our research looking at health and NHS, fairness has always come out as a clear overriding concern for the public. But how they understand fairness is different. For some, based on need, you need to give the service where it's most needed. And for others, equality for all across the board. And for ICS's understanding public perceptions and some of these beneath the surface of what fairness means and beneath the surface of prioritisation needs to be taken into consideration. There's an awful lot of complexity in the public's views. Thank you.
Great. Thank you very much, Kelly. So, Julian, if I can turn to you now. You've published a really excellent paper on this topic recently, which I know we're posting in the chat for people who want to take away and read. Two elements you addressed in that paper were the legal dimensions of this and the public legitimacy dimension. Might you be able to give us a little bit of a summary of around those issues?
Yes, Peter, it's good to be here and good to see you all. I'll cover that. There's a few other things I might pick up as well, but as Peter said, I'm Deputy Chair of the CCG in Cambridgeshire and Peterborough. I'm a recovering politician. I'm an academic at Jesus College. You can almost see my office behind me. And I thought Kelly's data was really interesting. A few years ago, with an academic hat on, we did a survey with YouGov to look at attitudes to inequalities in health, in wealth, and in power. And what we found was that the public were very concerned about any inequalities, particularly in health, that they felt that the life expectancy of all groups by income distribution should be the same, whereas they were relaxed about inequalities in wealth and in power. So the public clearly also does have a view about unfairness quite strongly, and that's another paper I can talk about. But Peter, the thing you asked me to talk about really comes from doing some thinking about the realities of decision-making in commissioning and how we think about the role of ethics there. So there's been lots of medical ethics textbooks, loads of philosophical articles written about how we allocate health resources, how we think about doing any of this. There is too much probably for any one person to actually even read. But my experience, having been now in a commissioner for 6 years, is that it's almost never used. And I'd be delighted to hear from everybody in the chat to say that commissioning decisions in their area are in fact driven by ethical concepts and rational decision-making models like that. But it's not how it works. In reality, from my experience in Cambridgeshire and Peterborough, from talking to other people, it's much more about which platform is burning right now, who has the most power in a negotiation to insist on getting funding, and which instructions have come down typically from NHS England or somewhere else above. It is a power dynamic emergency reaction system rather than something which is properly thinking about ethics in any way. And so we decided a while back to set up an ethical committee across Cambridgeshire and Peterborough system. There's been ethical committees inside hospitals to look at particular patients for a while. But what we wanted to do was to really start feeding information about ethical challenges that were being faced, about allocation, about all sorts of other decisions, anything other than here is patient A. Now, originally this was to do with COVID itself, but we have now made it broader and developed an ethical framework. And so the paper that you hopefully will put in the chat, if not, I'll put later, was one of the things that came out. We've developed an ethical checklist and various other things. But the idea is to try to come up with a way to help decision makers, resource allocators, to think about key principles of what we're trying to do. So how do you think about equity? Obviously, health inequality being a large part of it, but also how do you think about transparency? How do you think about sustainability? And I think those are really big issues. We also wanted to think about how to do public involvement well, and what you can learn from the public, and what are the right questions, what are the wrong questions. You know, Kelly pointed out in her words that you can do surveying, which will tell you some things, but unless you have a proper engaged conversation, you're often asking the wrong questions. We used to do lots of surveys when I was on the county council here, which revealed that the public felt really quite strongly that we should provide better services at a lower tax rate. And that was interesting, but spectacularly useless when it comes to actually trying to do anything. And so we've talked in that paper about how you might think about doing some deliberative processes. So deliberative opinion polls, for example, from Jim Fishkin have been around for a long time as a tool to get the public together and to find out what would they think, what would the public think if they had a chance to learn together, talk together, and really reflect on the nuances and the trade-offs. And it's an incredibly wealthy studied approach. It's used around the world, and it's what I think we need to start doing to move this agenda ahead. But I also just want to say a bit about why we still see inequalities in health persisting, despite the fact that for a long time the NHS has said it wants to do something about that. There are people who don't think about that, but enough do to care. Why do we still see some of the same behaviours? And part of the issue is that those who have, for example, excessive funding, GPs in wealthier areas, hospitals in wealthier areas, generally don't feel that they are doing better. They don't feel that they are over-resourced and in a luxurious position to spare help for others. We have been trying to do some work in Cambridgeshire and Peter. We did a change the diabetes enhanced services with a small pot of money and wanted to do that based on deprivation funding, because we know there are more problems from diabetes in poorer communities. And it was fascinating to see many of the same clinicians and others who said they were really concerned about health inequalities felt very strongly that their organisation should still get more money, even if their area was doing better. It was a massive fight to try to get any of those changed. We've been looking recently at primary care. And again, there's been various studies across the country which show that disproportionately there are more GPs in wealthier areas. There's more money available in wealthier areas, despite the fact that we know the problems go the other way around. We have to be quite robust to the point of some pain in some areas if we're going to make a difference. A couple of final thoughts, and then I will listen to much more interesting, or let you listen to much more interesting people. One is, we need to really rethink what healthcare is about if we're going to do much about inequalities. If we keep the system the same and just add a little flag, we will miss so much of the point. We think of healthcare, the public think of healthcare as doctors and nurses and hospitals and operations. And I think we should rethink what we really mean. If you take the fire service, they are amazing people. They will risk their lives dragging you out of a burning building, but they will consider that a failure to have prevented the fire. They spend most of their time, most of their effort on fire prevention, not on putting them out. The police have the Pelian principles, which say their objective is to reduce crime and disorder, not to go around nicking people afterwards. Reducing is the purpose. We are still stuck in healthcare, not thinking enough about that. And I would love to see us start to think about, for example, a hospital admission as being a failure to prevent hospital admission. That rather than thinking of hospitals and out of hospital care, we think of community care and out of community care, where we have these big buildings with lots of doctors in. If we could reframe what we're trying to do, then I think we could do much, much more about the preventative agenda. We could massively reduce the social determinants of health, the commercial determinants of health, as we're going to hear about more, and really make a difference. But we have to do that with policies that work. And if I can just finally flag up a wonderful paper by a student at Jesus College, Dolly Teas, who looked at obesity policies in the UK and did a wonderful analysis looking at what was in them, and found that by design, because of the way they were built, it is unsurprising that they all failed. So let's also make sure we think about how to do policies which are actually going to work, rather than just give a good, nice, principled headline. That's probably too much from me. Back to you, Peter.
That's great, thank you, Joe. We'll put that paper in the chat if we can track it down. So Swaran, turning to you, an Equality and Human Rights Commissioner for 6 years. What perspectives would you offer on this question for ICSs?
Thank you very much for inviting me, Peter. I want to first pick up your point about technocratic solutions by emphasizing the difference between complicated and complex entities. NHS is a complex entity. It is complicated, but it is complex. And the difference is not just semantic, it's profound. Take a jet engine, it's a complicated structure. It has thousands of parts, and no one can singly master them. But in theory, you could write a manual which would tell you exactly what each part does. The weather, or the human body, or society, or a living cell are complex systems. They have constant feedbacks which alter the initial conditions. So they inherently defy mechanistic predictions. We know every single law of how the weather operates, and we can't predict it accurately. The reason why I'm making this point is that it is tempting to see the NHS as a complicated system, and like you say, apply a technocratic solution, tweak this, tweak that. without thinking that because it's complex, there'll be unexpected and perhaps unwanted outcomes. I'll give you one example from what I know in mental health. In 2004, the Department of Health was convinced by several loud voices that ethnic differences in mental health in the UK were because psychiatry was institutionally racist. Between 2004 and 2008, in England, the Department of Health spent £650 million, £650 million on a program called Delivering Race Equality. Not a single patient was helped, not a single service was improved. Nobody pointed out that, we don't blame GPs on rising rates of obesity. We don't say, let's send them on fat shaming, diversity and inclusion classes. But the temptation, the seduction of a simple problem to a simple answer to a complex problem is very politically attractive, and also it serves lobby groups well. Now, from my Equality and Human Rights Commission report, I learned one important lesson. I led the sections on education and health in successive Is Britain Fairer reports. On every single measure that we could look at, white working class boys were doing worse on educational outcomes than any other ethnic groups. Our prediction and our belief that poor educational outcomes will somehow map onto Black and minority ethnic classifications just wasn't right. Human beings are not color-coded for differential outcomes. The color coding by, I mean, the way we classify things like ethnicity and race. These are proxy for very complex socio-economic and cultural variables. They don't neatly pigeonhole into those. So again, to understand a problem, especially a complex problem, something like health inequality, you need dispassionate and objective analysis, but the emotional response to these does not allow such an analysis. My final point is something like to do with what Julian said earlier. ICS should not, whatever they do, they should not fall into trap of playing one bit of the system against the other. I'll give you an example from mental health, which we've seen for 30 years in psychiatric care in this country. There was an ideological wind that swept the land saying hospitals bad, community good, and hospitals were closed. As if there was some magic healing power in the community that would make serious mental disorders and their disabilities disappear. And hospitals were replaced by these fragmented, isolated community services. By demonizing and resource deprivation of hospitals, we made them what we feared. We made them places of coercion rather than care. So it's very important that when we make changes, we don't, for short-term political or financial expediency, play one part of the system against the other. Let's deprive this bit and add to that bit. I realize I'm saying what should not be done because knowing what should be done is tricky. And if we knew the answer, we would have found it by now. So I'll stop there. Thank you. Peter, you're mute.
Thank you, Swaran. So Michael, turning to you, in your work, you've suggested some fundamental ways to think about this challenge. So what would be your advice, your thoughts for an ICS leadership about how they frame their thinking about inequalities and their role in allocating resources?
Thank you. I'm very challenged by Kelly's data because I've taken it as an article of faith that we have to work with communities, not impose things on them. And yet what Kelly suggested is, well, I'm caricaturing only slightly. Health inequalities, no, waiting lists. Let me paint for you three graphs without the slides. I'm going to put deprivation on the x-axis and a health outcome on the y-axis. And the first health outcome is COVID-19 mortality. And what you see is a remarkably smooth gradient. The greater the deprivation, the higher the mortality from COVID-19. I was then talking to some dentists, International Oral Health Conference. So I showed them another graph. The label was too small, you couldn't read it. So I put it in big print. It was decayed, missing, and filled. Dental caries. Identical gradient to COVID-19. Then I was talking to some heart disease prevention people, organization. So I showed them another graph. Childhood obesity. Identical social gradient. Now, if you go and ask people, look, I want you to think about heart disease. What should we be doing about heart disease? Oh, we've got to get people into hospital quickly, and we've got to make sure there's no waiting list. People could die, and it needs. And then you say, what should we do about COVID? Well, if people need care, they should be seen straight away, and they should get dexamethasone and the latest treatment. And what should we be doing about dental caries? Oh, well, maybe prevention. They'll talk about prevention, but it's due to diet and oral hygiene and low fluoride levels. The point being, they're all showing identical social gradients. They're all related to degree of deprivation. But if you ask people, what should we do about dental caries or heart disease or COVID, they won't say we should deal with the conditions in which people are born, grow, live, work, and age. They won't say we should deal with the social determinants of health. Does that mean we should ignore it? Does that mean the fact that COVID-19 mortality was 25% higher in the Northwest than the English average? That life expectancy in the Northwest dropped 1.6 years for men, 1.2 years for women in 2020, not because of lack of treatment, but because of the social determinants of health. Does that mean we should ignore it? I think we need to do a better job of education. And so my point about ICSs very much picks up what Julian said. We need not to think about inequalities just in the context of who gets care, who gets seen, but can ICSs, can the healthcare system address the conditions in which people are born, grow, live, work, and age, the social determinants of health, and the drivers in the economy? We produced, when I was president of the British Medical Association, then of the World Medical Association, we produced 2 reports each time about what doctors can do. And the nurses have picked this up, and they've produced a similar report for nurses. And we said 5 things, and I would apply this to ICSs. Education and training about social determinants of health. The second is seeing the patient in a broader perspective. If you're running a service to treat people and someone's homeless, treating their pneumonia or their leg ulcers and tossing them back onto the street is not very good practice, ethically, morally, practically, economically. The third, anchor institutions, looking at the wider impact of the healthcare system on the community, the environment, who's employed, and the like. The fourth is working in partnership, and that's key. The work we've been doing in cities and regions around the country, very much partnership working of the different sectors with local government, the health, social care, and other sectors, the police, the fire. And the fifth is advocacy, speaking up on behalf of the people we serve. In my view, ICSs potentially provide an opportunity to do things differently. It's been difficult to get healthcare services to orient their attention this way, not least because of funding problems. When you've got a backlog of several million patients, to say you should be doing other things. What? We're so busy trying to deal with this tidal wave. What do you mean we should be doing other things? With which hour of which day do you think we should be doing that? So I understand the difficulties, as well as understanding that the key drivers of health lie outside the health care system. But it's a great opportunity. And I would propose those 5 ways of operating: education and training, the patient in a broader perspective, anchor institutions, working in partnership, and being advocates for better policies for the patients and populations that we serve.
Thank you, Michael. That's great. So what I'm going to do now, we're going to go back round the panel just to get further reflections or questions of each other, but just to encourage those of you listening in to post your questions in the chat too, and we'll try and see if we can pick a couple of those. But Kelly, if I can turn to you, any further reflections that you've had in the light of how the conversation's played out?
Yeah, lots of brilliant contributions, Peter. And I think quite struck, because Michael was struck by my data, which I love, but quite struck by the point around, if the public aren't saying it's a big priority for them, does it then mean we don't tackle it? And I think that wasn't necessarily what I was communicating. I was communicating the public, it's not a top concern for the public when you ask them on the face of it, but when you get under the surface of some of the issues, many of them are interlinked with issues like health inequalities, and actually they understand more of the complexity than we realize on the surface of very simplistic polling data. But I would be curious on that basis to ask the panel, if I throw a question in the mix, really, health inequalities, this isn't a new issue. This is certainly not just a UK-based issue, not a new issue. It's been going on for a century more. And actually, there's been a lavish amount of policy attention in lots of different parts of it, quite disjointed. And some of you have touched on the issues today. What is the role of the public, in your view, then, on shaping some of the localized decisions that will need to be taken by ICSs? And how do you think they can best bring the public's perspective, but also get legitimate buy-in from the public to what's happening at a local level?
Julian, do you want to jump in on that one?
Yeah, no, I think, there's lots of really interesting threads we could talk about so far. In terms of the public's role, I think we have to avoid health doing things to people. And I think, therefore, it's really important, as Kelly says, to get that public buy-in. If you look in Ireland and various other places where they've had citizens' conventions, one of the things that they've managed to do is to get people to actually follow the conversation. You can't get the whole public into the discussion, into the conversation, but you can at least give them the idea that there is this thing which they ought to be part of and aware of. And I think that's going to be really, really important, because, as we've said, as Michael has pointed out so often, there is a limit to what we can do in health about any of this. If you look in Peterborough in Cambridgeshire, it has, I think, the record for the largest number of takeaway shops in a row. Those sorts of determinants of health are hugely important. They're not down to the NHS, but they are up to the public to have some opinions about, to be engaged with that, and to be also aware of why decisions may be made. At the moment, I think politicians, and as I said, I'm a recovering one, could often be too scared to do things because of the fear of backlash. That also means, though, that we need to build more trust in many of these areas with the public. So the NHS is in some ways very trusted. Doctors and nurses repeatedly come up very high on trust surveys. But I'm not sure that's true when it comes to more difficult pieces. When you look at health commentary about diet, when you look at health commentary about things, people don't obviously trust the system enough to act on it. And I think one thing I'd want to see, we talk about various different ethical principles. Equity is one of them. Transparency is another. And actually, I'm not sure the NHS is always as transparent about what's going on, about why it's doing things, about why it's suggesting things, as it could be. And certainly many of the partners who actually have to implement things out on the ground, they certainly aren't.
Swaran, any thoughts on this question of how we properly engage or better engage the public in driving this change?
Well, I think some of the change has to be driven from the top. I want to move the focus slightly, if I may. I've worked in Denmark for many years. I had a chair in one of the universities there, and I've known the country intimately for almost 20 years. One thing you notice about the Danish system, and broadly the Scandinavian countries, is that they have agreed as a society that health and education are too important to play politics with. So every time there's an election, there is no expectation that there will be a wholesale reorganization of the system, which we have here. Here, political victories lead to ideological changes to the system. And because the political lifespan is 5 years, you make changes, and by the time they embed, if another party comes in, those are reversed. We've seen that again and again. Whatever changes we make, I think we should find some way of having a conviction of sticking with those for a long enough period to see if they work. Otherwise, you're constantly, the 5-year lifespan, the political lifespan, then interferes with the NHS long-term planning. That's a kind of opinion. I can't prove it to you.
So just following on from one of your points, Michael, one of the questions that's come from the audience is how to focus on inequality when waiting list concerns are so great. Are there any observations you might have on how people might set about responding to the so-called elective recovery and do so in a way that perhaps makes a positive contribution to addressing inequalities?
Well, let me come back to what I was saying before about I found Kelly's presentation fascinating, so I wasn't, I hope, Kelly, I didn't sound like I was attacking it, but it very much how you ask the question. My guess is if Ipsos MORI had done a polling last Thursday, it depends where they did it, but what's on your mind? I'm guessing, I may be completely wrong, that the removal of the uplift to universal credit would be very much on people's minds if they were in the category that was going to be affected. For the rest, they might have seen it a bit like qualification for the World Cup or something, because it didn't affect them. But if you were about to have £20 a week removed, it would be the biggest thing in your life for that day, I would imagine. Now, that's likely to impact on health. The implication, the suggestion is that 300,000 more children will be thrown into poverty by the downgrading of universal credit. It's a key determinant of health inequalities. My guess is the people affected are very concerned about it. If you ask them about health on the same day, they probably talk about waiting lists, even though the biggest thing in their lives that day was the fact that they're going to lose £20 a week, £1,000 a year. But they ask them about health, they'll talk about waiting lists, the difficulty of getting to see the doctor. So a lot depends how we frame the question. And my guess is most people who have children are very concerned about whether they have enough money to feed their children and what's happening in preschool. And so I'm really struggling. You know, I can't justify why I believe in democracy. I just do. So I can't give you good reasons for it. But look at the challenges. Norway spends $30,000 a year in childcare, subsidizing childcare. The United States spends $500 a year per person. At Norway, 30,000. Now you could say, well, the US voted for their system and the Norwegians voted for their system, so that's just the way it is. Why are you bothered? Well, Child poverty is higher in the US than it is in Norway. Children suffer, health is worse, health inequalities are bigger. There are a whole set of things. Now, you could say, well, that's just democracy. The US has voted for having a rotten society. They voted for Trump for president. They've only got themselves to blame. And Norway's got a new incoming government. I'm just troubled by this. We know that if society invests in supporting families with young children, that will be good for those children's development, subsequent health, and the health of the whole population. That's actually a good thing to do. But if people say, no, I'm concerned about waiting lists, I'm not concerned about childcare, therefore we won't do it. We've got a communication problem here, I think. We've got to, and that's why I'm saying that ICSs need to, I would hope, look beyond what they do in their day job now, which is delivering health and care, and say, how can we deal with the social determinants of health? The quality of early child development is crucial. We may not be able to do it directly, but we may be able to put money into it. We may be able to work in partnership. These are crucial issues. And we may be able to affect the kind of policy that means that parents, for example, we know one of the reasons the Nordic countries have low child poverty is because two parents can work. And the reason two parents can work is because childcare is subsidized, $30,000 a year in Norway. So these are huge social policy issues. We in the healthcare sector see the final result of the failure of these good policies. But we've got to broaden our conversation and we've got to broaden our outlook.
So, Kelly and Julian, some advice to ICSs. If ICSs want to try to engage in this deliberative conversation that you're proposing, which is kind of founded in an observation that once you support people to get into greater depth and nuance around a topic, you'll get a more nuanced response. What kind of practical steps could an ICS take that could start that conversation with the public that they serve? Perhaps Kelly, do you want to kick off on that?
I think the key thing with any kind of deliberative event is it's not something that it is a scientific process. It's not just getting a group of people together to have a conversation about a topic. There are very specific principles to follow. We've actually produced some guidance which I can post into the chat rather than talk you through a guidance note on how you do deliberation well. In fact, perhaps one of your colleagues could dig it out, Peter, and paste it in the chat for us. But you know, there are very key principles that you need to follow to do this well, to get a good understanding and to take the public with you on this kind of journey. But as Michael said, public views, public perceptions and public buy-in are important, but they're obviously not the only thing. And there's a need and a desire to make progress and bring the public on this journey, as opposed to the public will be driving this process, which from some of the higher level numbers that I showcased you today is probably not the case. Another random point, if I can, Peter, because I don't know if I'll get to make it again, is in the time that we have left, the government have a quite wide-ranging levelling up strategy, which we're still hoping for a white paper to come out on soon, which is supposed to be more holistic than just transport infrastructure, jobs and investment. And it is supposed to be looking more widely at social and human capital and building that in parts of this country where it hasn't existed for some time at the same scale as other areas. So we will see what comes out in that white paper, but from the public's understanding of what they want to see through levelling up, they are much more satisfied actually with some of the sort of the transport and infrastructure parts that government may talk about more frequently, and less satisfied with the social and human aspects of their areas, their societies, and that's where the public see more desire for change.
So Julian, yeah.
So I mean, I'm fascinated to see what the levelling up actually says. It seems to be a lovely phrase with no meaning yet, but I'll be excited to read how wonderful it will be. And I think there's a fundamental issue as well with many of these things about which are the things that people observe. Because there's always a temptation politically to offer things that people will see, but also if you want to measure things, to look at things people can see. People can see a new road or a new train. They can measure or get a sense of how long they have to wait for a GP. It's harder for them to see that people are a bit healthier and that the environment is a bit more conducive to good behaviours. And that, so there's a real challenge about how we communicate that. But to come back to the actual question about how to do deliberation, because we've been talking about deliberative processes. In my paper, it talks about deliberative citizen work. You've used the word conversation. We also see words about consulting with the public or listening to the public. These are very, very different things. And I think it's important to know what they are. And if you want to do proper deliberation, and Kelly's completely right, it's a controlled process, you will need to feed in differing opinions. There will be people who will have a different view from those of us on the panel. You need to make sure, if you want that proper conversation, you get that balanced input so that it's a genuine piece. And I have to say, I think that's a problem with the NHS and various others, that the word consultation often means essentially, here's what we're going to do, and we're ticking a box to consult about it. And if, and I've seen too often, we did a consultation, most people disagreed, but we have to do it anyway, so we're doing it. If you have to be prepared to take the risk that the responses you get back from the public aren't what you wanted them to be. Because if not, you're not being honest and transparent with the public, and you won't be able to do that. So you can't just say, we must take the public with us. This is a comm strategy. They must go over there. It is about properly engaging, giving them the information to hopefully make sensible decisions, but accepting the fact that they won't always think that the sensible decision is what you thought they were.
So if just on that one, just in terms of going back to your paper, so if you do this process with your public and they give you and you reach a clear sense of a majority view, and you decide you're going to do something different, what then become the key things that you have to be able to demonstrate to make that a legitimate act?
You should always be free to say, it's very interesting what the public have to say, but we're not doing it. That, I'm okay with that as a process. We then need to know that this isn't what the public think, even after you've had a conversation, explain the constraints. It's not just as simple as public vote on some things, but I think there's little point going to all the effort of getting deliberation to happen. I was advising a CCG elsewhere, an STP elsewhere about this, and they said we're very keen towards deliberation. We're very keen to do this, but we've worked out what the answers need to be afterwards. It's just not worth putting the time and effort in for a dishonest process like that. So I think you can overrule them, but I wouldn't advise starting if you're planning to do that at all.
And Peter, even if that happens, the chances are you'll have learned some very useful stuff from the deliberative process about the nuances, how things resonate with the public, how you need to tweak how you're going to do something and not just what you're going to do. And so you can show that the process was still very valuable and you have made changes as a result. It may just be that it's still the right thing to do, even though there hasn't got 100% public backing. So it should never be a useless or a fruitless process.
Michael?
Yeah, when we set up the World Health Organization Commission on Social Determinants of Health, we had 9 knowledge networks, scores of people, actually hundreds of people around the world working on gathering knowledge about the determinants of health, what works. We had a distinguished group of commissioners. We met for 3 years, wrote a report. Now, I'm not speaking in praise of elites, but I'm saying that when I went into it, I didn't have a clue about much of this. And are we expecting people to understand all the scientific evidence without going through that kind of process. And what I had a very interesting experience in Liverpool. I met community groups, and I gave a lecture, and then they had breakout sessions, and they came back and they said, we don't want an outside expert telling us what to do. I thought that was a reasonable response. And I said, you'd like to do what you want to do, even if it's useless. It's better that it be yours than it work. So now we had a standoff with me and 200 Scousers, and they said, well, okay, you tell us the principle of what works and let us figure out how to do it our way. That made sense to me. So there's a lot of knowledge out there. We don't expect people to come with the knowledge of the scientific literature. The evidence is really important. But what they said to me in Liverpool was, okay, you tell us what works, but let us figure out how to do it our way. That makes sense to me. That is engaging people, and it's the right role for knowledge and expertise as well.
And I think in the sort of best examples I've seen of deliberative processes, that's a key part of it, isn't it? The process draws in that kind of expertise as a neutral input. We've got 2 minutes left, so I'm going to give each of you 30 seconds. This is a question from the panel. If you had an extra billion to spend, I'll pick a billion, that's 10 billion, whatever it is, as a government, and you were seeking to improve health inequalities in this country, and you could only spend it on one thing, what would you spend it on? Michael.
I've been asked that question about 3 million times.
Okay, sorry.
And I would say, and my answer is, the one thing I would do is put equity of health and well-being at the heart of all policy making.
Swaran?
What I'm going to suggest may not need billions of pounds.
Right.
I'd like somehow for us to agree that these are shared problems. These are not problems for one part of society or for another, that these are common problems, these are shared problems. The Scandinavian model works because they see themselves as a closed-knit community, as a shared. So in say health, if the NHS doesn't do something, for instance, look after kids who drop out of care from camps, the cost falls onto the social system or the criminal justice system. And so NHS has no incentive to provide care because the consequences are elsewhere. Unless we see this as a shared problem, we will carry on providing fragmented solutions.
Great. Julian?
I mean, there's so many things that need doing, you know, education, financial support for people. But if I was going to pick one thing, it might be properly to invest in public health. The amount of money put into public health is way less even than it was supposed to be from in the 2012 legislation. It has come down, you know, it's about a third of what was originally envisaged. If you invest in public health, and particularly in public mental health, which is, you know, largely ignored, I think that could start to make a really, really big difference. If you shifted everybody along that bell curve on mental health, so that everybody who has a bit of a problem has a bit less of a problem, we have fewer people with serious problems, that would be transformative for inequalities, it would be transformative in the workplace, it would be transformative for society, it would be transformative to economy, and it would be transformative for millions of people.
Great. And Kelly, to round us off.
Well, I guess two things from me. So three. One, I would ring fence it so no government can change their mind about how to spend it. So put it into some kind of endowment so it actually goes on the things that you want it to go on rather than shifting with political cycles, as one of our panelists said earlier. And then secondly, at either end of the spectrum, fixing the issues in the nearer term, giving some proper money to general practice and primary care, who often get left out in terms of scaled funding decisions. But secondly, really thinking about the early years and opportunities for all in the longer term and trying to resolve some of those issues too.
Great. So I've failed because we're 1 minute past 10. So I've kept some people from their appointments. That was a great discussion panel. I wish we'd had all day because I think there's so many other places we could have gone in that. But I really do thank you for giving your time this morning, and thank you to everybody who joined the call for giving your time. There's more sessions in the Insight Festival coming up this week. So please, if you've got any more time to spare, join us for those. But thank you very much. And that's the end of the session.